on research design by Dr. Susan John, consultant clinical epidemiology, Rajagiri Hospital, Alua. She has completed her MD in community medicine and has done her postgraduate diploma in epidemiology. Her keen interest lies in research methodology and its ethical concerns. She has been part of multiple research methodology workshops as faculty and is currently involved in research activities at the hospital. She is also the member secretary of the Institutional Scientific and Ethics Committee at the hospital. Over to you, Suzanne, ma'am.
Very much for this opportunity, and it's always a pleasure to find more and more people being involved and interested in the true nature of research. So mostly as clinicians, we are interested, or our focus is on treating patients. So, to a clinician, when we approach and we say research requires a lot of work. So initially in the community, that was like, okay, I have to do something. Okay, research is some paperwork. But then later on, research has more and more interest. So I won't take too much time. We have very limited time. So we're moving on to the topic. So let's look at this house. Okay, so the basic idea why we need a home. Why do we need a home? We need a home as a place of shelter, as a place where a family gathers in, or a group of individuals who come together and stay. But does every home look like this? Definitely not. A home can look, in different ways. So in that manner, when we get, say, a new drug, okay, there are different aspects that we might like to look into the drug. As Dr. Pratibha was already mentioning, what is the aim of our study? That is probably the most crucial question that we keep revising over and over again through our process of designing our entire research. So, right. So it can be the safety. Is this drug safe? Can we give it to everybody? What are the interactions? So suppose a person is taking some other medications. Would it interact with that drug? How effective is it? That is, if I give it to 100 people, are all 100 people going to get cured? Or are they going to get better? What dosage can I give so that they will not have any other side effects? What are the indications? Okay, so when should I give this drug and what can be the precautions? So as rightly ma'am has already mentioned, what we need to focus on the study because is the most important thing when we take a new drug. So as coming to the earlier point, we need to build a house, right? So based on what we need, right? So what happens most of the time is that we have a lot of raw materials. That is how we approach the study. That is, I have to know how effective is this particular drug. So I have this drug, I have my research team, I have my set of patients. The drug is given and I will know if the drug is good or not. Okay, so that is the mindset with which we try to approach a paper. So we got all the raw materials. Now the challenge is, how do we go ahead with this? Or how do we design this in such a manner that what we consider as good is actually the good? And what are the factors that we must remove so that we can really find out if there is an actual good in it? Okay, so we have this, our set of patients, we give them the medicine and we know some are improving, some are not improving. So we have a plan and with that plan, we think, yes, this is how our house is going to look with all the raw materials. But basically the gap is we have the raw materials and we have an idea what our final outcome should be. That is, the drug should be good for the patient, or is the drug effective? How can I bring about a paper? Or how can I show it to the world that this particular drug is effective or not? How can I move around? So the most important, or one of the next most important step after knowing what we need to find out is to find out how to go about it. So it requires, scrutiny into each and every detail of what we have. Just like, what do we consider as a good outcome? So that again comes under our aim. So is it like the person who, when we are giving a particular drug, if the fever is just moving away, then is that an outcome? Or do all the symptoms have to go? Then is that the outcome that we are looking at? Okay, so how do we go about it is the most or the next most critical step. And this is missing in a lot of research work that we see. We have the materials, we have our concept, but deciding and specifying and the route to go about it is what we are going to deal with in research designs. So this is a very interesting quote that I found. So it's written in, yeah, in many ways, the design of a study is more important than the analysis, because a badly designed study can never be retrieved, whereas a poorly analyzed one can usually be reanalyzed. Consideration of design is also important because the design of a study will govern how the data is to be analyzed, or how we can understand what kind of inferences we can give to the scientific or to the community. All right. Right. So we have research design. So research designs, the first thing that we have to look into when we think about our research design is that what is it going to be? Are we just going to observe the patient from afar, or are we going to do something to that patient from our side? So the most important consideration that we should have in mind is it an observational study or is it an interventional study? So if we are allowing the course of events to go on, that is, as an external person, somebody else is giving the drug, some other persons don't receive the drug, how they both progress on. So if we are just standing outside having no influence on that, then we are having no active intervention into it, and it becomes an observational study. So what are the different types of observational studies that we can look at? So broadly, they are classified into descriptive studies and analytical studies. So descriptive studies, as the name mentions, is we are describing a particular condition. I think one of the topics we all might be concerned, or we all would look at to, is COVID. So initially when COVID came, our major concern was what does COVID, how does COVID present? So our initial papers or the first report we had was it presents like pneumonia, or if this many people have it. These are the first symptoms. So when we are just describing something, it becomes more a descriptive study, or that is our descriptive study designs. It involves case reports, case series, and new interventions that we are bringing about. So somebody is doing a new intervention, and what are the outcomes of it? Just describing that intervention comes under descriptive studies. Now, analytical is what causes COVID? How can, or what will be the factors that are possibly involved that a COVID should spread from one person to the other? So we are not just looking at COVID per se, we are trying to analyze what can be the reason why COVID came, what is the reason why COVID is spreading, how can it spread, and we all know that this kind of research helps us to bring about the preventive measures. So there are different kinds of uh, analytical studies, which include our ecological studies, cross-sectional, case control, case cohort, audits are there, validating prediction tools, and even surveys are to an extent a type of analytical studies. Another kind which we can put under observational will be our diagnostic test evaluation. It's very shortly put where we compare a new test with an existing gold standard test to find out how good is this new test when compared to a gold standard. Now, in interventional studies, we are doing an intervention. Okay, so a particular method is being applied, and usually there is no known treatment. So for one group of patients, we give a placebo. That is, we give something that looks like a drug but is not actually a drug. And on the other patient, we are giving this new drug, say most of times in cancer patients. So they are at their end of life. We need something. We have a drug that looks like a possible cure. So what happens is we are doing an intervention at that point. Now the crux there is, how can we do this intervention? So if any kind of intervention is from our part, then it becomes an interventional study. And these interventional studies can be randomized or non-randomized. Right. So under non-randomized studies, we have those unrandomized studies. We'll come on to that. Quasi-randomized studies, and even before and after studies are thought to be a type of non-randomized studies. Okay. And then under randomized studies, we have factorial studies, cluster randomization, and the stepped wedge design. Okay. All right. And also a third subset under research designs we have are analysis of already published research, under which we have the systematic review and the meta-analysis. Right. So moving on to a brief description of each of these studies. So as I said, we have our descriptive studies where we are describing something. Now, whenever we talk about case reports and case series, it's taken as like it is not so important, or it is not, what can it really give in research? But let me bring about this example of this disease, where in 1981, 5 cases of pneumocystis carinii pneumonia was reported in healthy males in US, Los Angeles, of which all of them were categorized to be homosexuals and 2 of them died. Now, in that same paper where this case series was being published, the editor also put across a comment that this is probably a cellular immune dysfunction related to a common exposure and a disease acquired through sexual contact. In 1983, there were recommendations for prevention of sexual drug usage, then occupational transmission based. So they only presented what were the symptoms and what happened to these people and what was the disease. Okay, so it was just a series of certain few patients and they described what they found in them. And from that description itself, they were able to find out measures on how to prevent it. And it was way after, actually, it was in 1983 later on that Luc Montagnier and his team went on to first describe the HIV-1. Okay, so this is how the story of how AIDS was being exposed to the medical community came about. So this makes us understand how relevant case report, so we can have a single case and we're describing why it is different, why it does not fall to our usual known set of diseases, and how it can later on bring about a knowledge of one of the most biggest epidemics, right, in the world. Case series where we have a set of such cases, common clustering, right? So in case of our COVID, that was the first report of the world, 40 cases of pneumonia, unknown cause, was being reported in Wuhan, China. So we should never underestimate that is my point that I would like to put across, the role and the importance of case reports and case series. New interventions, I have already mentioned. Just a word on diagnostic test evaluation. So diagnostic test evaluation is where, suppose we are having a new screening test. Suppose I have the ultrasound so I look at a particular breast cancer lesion. Okay, so using the ultrasound, I want to find out how much can it pick up from a lesion. How much can I pick up the malignant potential? So that when I look at the patient by just doing a USG, I can say, okay, this is more likely to be malignant. And so we have the USG, but then we always know to pick up the malignancy, we have our gold standard, which is the biopsy or the histopathological report from the pathologist. So what we're trying to do is how good is this ultrasound when compared to our gold standard in giving out a result. Okay, so under the diagnostic test evaluation, we have many parameters, including which mainly includes our sensitivity, specificity, and likelihood ratios, predictive values, and so on. So that is one subset that comes under observational studies, which is also of great relevance. Now, moving on to analytical studies. So as earlier mentioned, in analytical studies, we are trying to find out a relationship, some association, some relationship is there. So is there a real relationship or not? That is the advantage of analytical studies. Under analytical studies, we saw a long list. Let's go through them quickly. So ecological studies is where we study, or also known as aggregate risk studies. So here we study whole populations. Like again, let's take COVID. COVID is easy to relate with. So we have US, we have India, we have China. So we are taking populations per se. We're trying to find out what are the exposures, what are the factors. Was there lockdown? Was people following preventive measures? And what was the outcome? So there we are taking the population per se as a whole population. So what happens is that now in some parts of China, or say some parts in India, Kerala itself can be maybe mentioned. That is, our health model has been actually brought across. So when the preventive measures were well taken, the way the COVID cases were going had a different pattern when compared to many other states in India. Right? But what we were looking from outside is India as a whole. So that is what one of the drawbacks that is mentioned in ecological studies is ecological fallacy, where an individual is sometimes that there is a group of individuals who may have a different characteristic, but that is buried under the overall picture. Nevertheless, to study big populations, we can use ecological studies. So where we are trying to find out what is the relationship between a particular exposure, say preventive measures, if use of masks, proper hand hygiene, it was being properly or very strictly done in the population, can it prevent COVID? Okay, so when it is done in populations, it is, or in big groups, it can be called as an ecological study. Now, the next is what we almost always see is our cross-sectional studies. So I am a researcher. I want to study, is cholesterol, dietary cholesterol, real risk factor for cancer? Okay, so at this point in time, I am going to go across where I work. I'm going to find out people who have had cancer, or who have cancer and who do not have cancer, not where I work, probably in a, I'm going to go to 2 OPDs, or I'm going to go to the community, simple as that. So I'm going to find people who have cancer, who do not have cancer. So this is at a point in time, say for 1 week, for the next 1 week, I go out and I'm meeting people only at one point. I'll meet them today. Okay, you have had cancer. Your dietary intake was this good. It was this bad. So I meet 1,000 people, but I meet them at one point in time. I'm not following them up. I don't go back to them. I don't follow them, their medical records. So that is what is the crux of a cross-sectional study. So we are meeting, or that particular patient, how many times is the patient being part of our study? That is where we have it called as a cross-sectional. We are cutting it across, cross-sectional. Okay, at one point in time, we meet with that patient and we are trying to find out what was the outcome, did the person have cancer or not, what were our possible risk factors. Okay, so that is the basis of how we do a cross-sectional study. So mostly we do use these when they are not changing over time, say chronic diseases and genetically determined diseases. They don't change over time. Their presentations or later on manifestations may change, but not their presentation. So the defect in these cross-sectional studies is that you are meeting that person at a point in time. So we cannot really say if one was the cause of other. Okay, that is, when I meet this particular person, the person may have had stress or fat. So fat, okay, we may get by taking the history, but then there are so many factors which we cannot ascertain that it happened before the disease. Only if something happens before the disease, we can say that that factor led to that disease. So this causality that it leads to a disease is not, or we cannot pick it up from a cross-sectional study. Cross-sectional studies can be descriptive and analytical. It comes under both headings. If you're just observing it, it comes under a descriptive cross-sectional study. At one point of time, you're just observing COVID patients and their symptoms. And if we are finding out, okay, they were obese, they were of older age, then it becomes analytical. Right. So moving on to the next subsets of analytical studies, we have case control and cohort studies. All of us would have heard this. How do we go about it? So case control is, as just we have to keep in mind, is that we have two subsets of population in this study design. That is the cases who have the outcome. They have cancer, and the controls who do not have cancer. So when we are starting the study, we have these two outcomes. And then we are going to find out what were the factors. We will study, were they obese, or what was their dietary consumption, stress, exercise, family history. So we study a list of factors, but we are from the outcome, we are going backwards. So case control studies are highly favored because they give us a better idea on the causality, or which we measure as the odds ratio. They are inexpensive. You can quickly complete it, and even rare outcomes. Those who have this particular disease, those who do not, we can actually look through case control studies. The defects are mentioned as recall and selection bias. Won't go in detail. Recall bias, very simple. Those who have a particular disease, you ask them, did you have fever in the past 7 months? Now, when we have a disease, we'll remember each point. Like, yes, I had a fever, say 2 days back. I went to the doctor. But I suppose I don't have any disease. I'll be like, fever? No. So we may not be so accurate in getting that particular history. So these are the two major drawbacks that we can have in a case control study. Now, cohort study. Cohort study is the basic concept of it is that we have a group of people. Okay, so suppose I'm taking the entire population in Kerala and I'm going to follow them up for the next 1 year to find out how many of them develop stroke. I'm not, so I have a cohort of people. So it is a group of people, and then I will follow these people to find out if they have, how many of them developed stroke, how many of them did not. So where we are standing, our starting point is we start somewhere and then we are traveling to an outcome. Okay, so there is a movement, like they say, a forward movement most likely. Most of the time in a cohort, that is what we see. Okay, so the outcome we are observing in the point of time. Now, these probably are much higher in the grading of the scientific quality, because here we can study multiple risk factors more clearly. Like you can see at that point in time what is the status, what all that person is developing during the period of time, and what was the outcome. So cohort studies are definitely have an upper hand over case control to find out the causality in a better way. Different types of cohort are there. Prospective is when we go forward. Retrospective is in our cohort, but we follow them up back in time also to find out with respect to their medical records and in great detail, okay, to find out the risk factors. There is also a subset case cohort. So case cohort simply stands for cases who have an exposure, and cohort are those without the exposure, and then they are matched. Okay, so the advantage of cohort studies is that they have a direction. We know most of the time what happened first and then what came after that. Did the outcome happen before the said risk factor? Helps in causality, but then again the disadvantages are it's more expensive, more resource consuming, and then rare diseases it's usually not applicable. Audits and surveys are actually, if you think of it in a more scientific manner, we can put it into our proper study design. So what we do in audits is we compare the existing practices with the STET standard. Okay, so it's like an analysis. Is it going as per the standards? Surveys also. Surveys is where we collect a lot of data. So these are said to be cross-sectional because we are not following up. At one point in time, we are taking their survey. So it can be what is your knowledge on COVID, or what do you think about the practices in COVID? Do we need to follow them at this point in time? So a factual and attitudinal surveys. Again, these can be descriptive or analytical. Now, moving on to, so that is, it completes our subset of observational studies. Now we are moving on to interventional studies. So interventional studies are where we do an intervention. Now, here the crux is when we do an intervention, is our study population randomized or non-randomized? So what is that basic idea of randomized or non-randomized? Randomized is when I have to give a particular treatment, every person who is in that, let's say, population has an equal chance of getting that treatment. Then we say there was randomization. But suppose when I say I will give this treatment to the first 10 people who are coming. So what happens? Everybody doesn't get an equal chance. Only those first 10 people who come are going to come, right? So there is a non-randomization. There is an intervention, but then every person does not get an equal chance. So that is the crux of an interventional study. First, was there randomization or was it not non-randomization? So in our unrandomized studies, what happens is that the investigator, that is suppose a clinician says, I'm going to do this intervention for patients who are on surgery on Wednesdays, or this particular patient that I think this patient is more likely to recover. So what happens? It will show a false positive ratio that this method is good because less aged young patient, no comorbidities, this patient is going to get better. Okay, so that is what happens in unrandomized studies. There is an intervention, but because of the selection bias, you can have an overestimation or underestimation of the true treatment. Okay, so under this unrandomized or non-randomized studies, we also have quasi-randomized. So here it is not the investigator saying, I am going to treat this particular patient, but they will say, okay, those who are coming on every Friday, those who are born on the, like every odd month will get this treatment, and every even month. So there is not equal chance for everybody, but some kind of randomization is done. So that is how under interventional studies you have pakka unrandomized and then quasi-randomized studies. Now we move on to randomized. So in randomized trials, the concept is that when we do an intervention, every person who comes has an equal chance of getting one intervention or the other. Okay, so mostly what we see are parallel trials. So what happens is we have say 10, 30 people are going to come for our study, and we will first randomize them. So we will say that out of this 15 people are going to get one intervention, intervention A, and 15 people are going to get intervention B. So you have two parallel groups, you will follow them up, see which intervention was better. Another way is crossover. So crossover is where study group 1 got intervention A, group 2 got intervention B. Suppose it's a drug that we are giving. Cannot happen in a surgical procedure. So what happens is after the effect of the drug goes from the body, it is washed out, that's the term used, then we will cross over so that group 1 will receive intervention or drug B and group 2 will receive drug A. So both in the advantage is that both groups have received both the intervention. So you cannot say that you kept away this particular intervention. It is very hard to pull it across practically, but again, it has its own merits and demerits. So the best thing about an randomized study is that it removes away what we call as confounders. Won't go into that. So let's move into factorial designs. So when we think about interventional studies, we only think about one intervention, right? But the advantage of factorial designs is that it allows us to test more than one intervention. So it makes combinations where some of them get none of the treatment, some of them get most of the treatment, say there are 1, 2, and 3. So based on the group in which they are placed, this design will help us to analyze different kind of interactions, improvement. So it is a higher way, okay? So it allows the testing of interactions even between the different interventions. Then we have also cluster randomized designs. That is, suppose I want to do an intervention. So I have to do vitamin A supplementation, or let's say the iron supplementation. So I cannot go to one school and give 4 children iron tablets and 4 children, I will not give them iron tablets. That is not going to work, right? The children will be like, what is this going on, right? But suppose I go to 10 schools and I give them iron tablets as per their weight and their age, and I give another 10 schools, I give them something else like a placebo. So I have a cluster. One school is one cluster, but I have randomly picked up. So each school had a chance, equal chance of coming in that study. So we can do even like that, behavioral studies, not necessarily drug studies. So that is where it is taken off from the patient level and it is given as a community level or a group level. In the hospitals, execution by the treating team, say one doctor has one particular way of doing surgery, another doctor, same problem but a different method to do surgery. Okay, we won't go into the details. And the final one we want to look through is a stepped wedge design. So here what happens, it's theoretically it says that each cluster will first provide data for the control condition and then cross over to the new intervention. So you have different clusters, say 10 hospitals. So before they start the drug, whatever is the standard practice, they get details from all the hospitals. Then they give the drug and then they take the new values. Okay. So there something like a before and after. Okay. So the duration of this is periods when the drug is given all may vary, but there is definite data. So this was originally used in vaccination studies, and these are considered alternatives for complex interventions. All right. An analysis of published research are again, that is, we have a lot of research data coming. But then every researcher need not have an enthusiastic and a genuine heart like you present here. There may be people who may do research or publications with an ulterior objective. So when we take research papers, we compile together what literature we have on them, and an analysis is done on that to find out what is the best method possible. Okay, so we have systematic reviews that have a definite methodology and finds out, okay, was this particular drug really good, or was it just hype, just an overhype of that drug? Meta-analysis is where we will do calculations, put up plots, and find out what is the best thing that this drug, what is the best outcome the drug has achieved in different countries and across different studies. Okay, so whenever we go for a research design, always things that we should consider is, what is the aim of our study? What is our research question? Boils down to that. What do I really want to look at? And then think about it. If I want to just describe about something, it comes, is it observational, or am I doing some kind of intervention? Do the division there. Then, if it is observational, what is it? Am I just describing something, or am I trying to find out is a relationship between two factors and an outcome? And if it's an interventional, can I stay back so that every patient will get equal chance of being involved in one intervention or the other? So that is how we have to find out from our aim what kind of hypothesis we are trying to generate, the logistics. We may want to do randomized trials, but then we may be the only person, we have a hectic department. So maybe we should go for observational, analytical. So what resources we have in hand, and ethical concerns, definitely very important, especially in our today's age. Just one more slide, where in our era of evidence-based medicine, this is our pyramid hierarchy of evidence, where from case reports, the stronger quality of evidence comes from cross-sectional, case control, cohort, RCT, and then our published studies analysis. Okay, so that is just once again a look at our different study designs, and good luck to all our researchers. Thank you.
Thank you, Suzanne ma'am, for the wonderful session.